Welcome everyone to the webinar, the first webinar of 2023. It's webinar number 6 of the ERN GUARD-Heart webinar series, and today we will talk about pediatric arrhythmia emergencies, and would like to give a special thanks to and special welcome, of course, to the moderator of today, Dr. Sargela Pugada, and the speakers of today, Professor Janucek and Dr. Tafakova. Today it's about thematic area 1 and 3, and I will pass the word to Professor Janucek, who will present the first 2 cases, and then Dr. Tafakova will present the 3rd case.
So good afternoon, everyone. I'm Teresa Tavacheva. Professor Janucek is next to me, and we are sitting in our office in Children's Heart Center or University Hospital Motol in Prague. And today we would like to talk about some nightmares for electrophysiologists and cardiologists, but I dare say it's not only for these specialties, but for any pediatrician out there. The topic is pediatric arrhythmia emergencies, and we prepared 3 cases of children who have been treated here recently, and we would like to discuss the steps and measures we took with you.
So I'll be presenting the first 2 cases. Apologize for the delay. And these should be pediatric EP emergencies or even nightmares. So this is the nightmare for every pediatric cardiologist, and even for an electrophysiologist may be a nightmare. And the first case is a 1-month-old boy presenting with tachycardia, heart failure, and circulatory shock. And the child has had a history of tachycardia, dyspnea for 12 hours before admission. In our department, at admission, there was a tachycardia with a heart rate of 300 beats per minute, shocked periphery, no pulsations, hepatomegaly. Echocardiography showed a very low left ventricular systolic function with a shortening fraction of 9%, with a massive mitral regurg, and the child had severe metabolic acidosis. So the question was what to do, but of course, first look was at the ECG, and this was the ECG. This is recorded with 50 millimeters per second, so it shows a very fast narrow complex tachycardia. As you can see, we can see very likely the P waves here, which are probably negative in 1 and negative in 2, 3 AVF. And actually we have several options what could be the diagnosis, including atrioventricular reentrant tachycardia, which would be common in this age. At this age, atrioventricular nodal reentrant tachycardia, quite uncommon at 1 month of age. Atrial flutter, maybe. Junctional ectopic tachycardia with retrograde AV conduction may be also an option, and focal atrial tachycardia. So we were uncertain what diagnosis this should be, and we got next ECGs. Here you can see what we have recorded further on without giving any drugs so far. So there was again the running tachycardia, and then the tachycardia stopped, and we saw 1 sinus beat, and then the tachycardia reinitiated again. So this picture will show us that there is some kind of P wave of the first tachycardia beat here, and the P wave is quite late. It's not, it doesn't have a short RP interval as we would probably see it with a normal accessory pathway. This RP interval is long. So this is the first ECG we got further. The next ECG was this one, and there was already wide complex tachycardia, and actually we didn't know at this point whether this is a ventricular tachycardia associated with the heart failure situation, or whether this is just bundle branch block associated with the original narrow complex tachycardia. At this point, we have decided to record the esophageal atrial ECG using an esophageal lead. And this is the recording. And actually, if you look at this recording, and these are the QRS complexes here marked, and these more sharp deflections are the P waves, you may realize that there is more P waves, actually slightly more P waves than QRS complexes. So the atrial rate is faster here. So now you have some more clues to decide about the diagnosis. Most people voted for IV reentrant tachycardia, which would be common at this age, most common reason for supraventricular tachycardia. But actually, if you are looking at this last ECG with the esophageal recording, you can really see there is no regular relationship between QRS complexes and the P waves recorded here from the esophagus. So we have a long RP interval here, a short here, a even shorter here, a coincidence of QRS and P wave here, again here, very short RP, very short RP. So there is actually a degree of AV or VA dissociation which is not compatible with AV reentrant tachycardia. The same would apply for AV nodal reentrant tachycardia. It may still be atrial flutter, but again, if you observe the tracing, here we have termination of the atrial rhythm. So it's quite unlikely for atrial flutter just to terminate for one beat and again reinitiate. This will be very uncommon behavior of atrial flutter. Junctional ectopic tachycardia with retrograde conduction could be possible again if we would have either one-to-one conduction or less P waves than QRS complexes with a degree of retrograde block. But here in this case, we have slightly higher atrial rate here in the tracing than the ventricular rate. You can see it here in those two complexes very nicely, for instance. So again, junctional ectopic tachycardia is not an option here. And the right answer is focal atrial tachycardia, because we have an independent atrial focus with different degrees of AV block or with normal one-to-one AV conduction. And ventricular tachycardia obviously should not be, because we have a narrow QRS complex tachycardia if we just look at the first rhythm. So what would you do now? And I hope I can move, and I can't again move.
Jan, maybe it would be good if you could put the first ECG, because probably the discussion was between the first ECG was not that clear, and here with the esophageal pacing, you can maybe point out the difference, but it's true that in this ECG you have a very regular retrograde P wave in every beat, yes, which is not exactly what you see in the last ECGs, and probably this looks more like an AV nodal reentrant tachycardia compared to the last ones that you have clear VA dissociation. Maybe we could think that there are two types of tachycardia, or maybe the patient is so ill that maybe it's presenting with a second type of tachycardia more related to a more severe hemodynamic condition.
It could be, but I don't think it's two tachycardias, because we have seen from this running tachycardia some degree of AV block, and again into one-to-one tachycardia. So I think it was truly just one rhythm, and we could not stop it with adenosine. The tachycardia actually was running further. So I think I will show that in some further slides, what was the further course of the patient. And but looking at this ECG, you're completely right that we were also thinking of AV reentrant tachycardia and hoping to solve the situation very fast with adenosine, which was not actually the case. So I'll move over the slide that we already saw. So our diagnosis here was focal atrial tachycardia. And what are the management options? Okay, of course, we have a severely ill child, so we intubated the child, put lines in, corrected metabolic acidosis. And what kind of specific treatment would you choose in this case? And there is also, poll can be opened now, given the fact that we have a diagnosis of focal atrial tachycardia. Most people voted for cardioversion. Some voted for ECMO, some for adenosine, almost nobody for digoxin, some for verapamil, nobody for lidocaine, and some for esmolol. So the first thing, cardioversion, it's of course an option if you have tachycardia which does not interrupt with sinus beats. But once we had a tachycardia which repeatedly interrupts and then again restarts immediately, probably cardioversion would do just the same. So it would not solve the situation. ECMO is a reasonable consideration, and I think ECMO service was alerted at that moment, but it takes some time before ECMO is prepared. So I think, and we will come to that in the conclusion, that ECMO, of course, is the right consideration and you should be prepared. Adenosine is again the same situation. You could use it diagnostically, but once we had the diagnosis, it would not be helpful because the only thing that we could get would be either AV block for a few seconds with running tachycardia or suppression of the focus with reinitiation of tachycardia after adenosine is washed out. Digoxin is a drug that takes time to work, and in this case it would increase the degree of AV block and probably not be helpful immediately. Verapamil is a dangerous drug in children like this with heart failure, small kid, 1 month. It leads to severe decrease in myocardial contractility and may even cause intractable refractory cardiac arrest. So we would not use it in any case of like this. Lidocaine would not work in this case. And esmolol, again, probably with this kind of a child having very poor ventricular function, massive MI, probably will not stop tachycardia and lead just to circulatory worsening. So what we did, there are other options. Okay, yes, you're right. Propafenone, 9%. We would actually hesitate to give propafenone despite the fact that it might suppress the focus, because propafenone is decreasing the conduction velocity in the ventricles and may lead to aberrated or aberrant tachycardia with even more hemodynamic compromise. And amiodarone, of course, is an option because it's a drug that has a potential to stop such focal tachycardia, again, maybe associated with some hemodynamic instability if given as IV bolus and continuous infusion after that. So actually, there are several options, but none of them is really nice. But we had to try something, and I will try to show you what we have tried. But now again, I try to move and nothing happens. And
Jan,
okay. Yes.
would you consider one of these options as ablation directly?
Not at the moment. We would have to put, if we would really not be successful with any anti-arrhythmic treatment in child like this, we would have to go to ECMO and then decide what to do. But basically, with focal atrial tachycardia, you should be able to to get it managed by drugs at 1 month of age. So that's more a theoretical option than a true option, I think. So we decided to give amiodarone, and by doing this, we had no true effect. So we still had a tachycardia which was slightly slower, 250, one-to-one atrioventricular conduction and white QRS complexes. We lost completely peripheral pulses, and we had a further clinical deterioration. So the question for us, what to do now, very fast, because otherwise, if not going on ECMO immediately, we would have lost the child. And so what we did actually, and I'll show it to you. And that's something that's often forgotten, but besides pharmacological treatment, we may use electrical treatment of many arrhythmias we deal with, even acutely in children. And so what we did was transesophageal overdrive pacing. And using this lead in the esophagus, we started to pace. And this is the tachycardia before pacing. And we started to pace with 300 beats per minute from the esophagus to achieve capture and to increase the atrial rate up to a rate where we could achieve 2-to-1 AV block. And actually, that's exactly what happened. Here you have the pulse oximeter curve without any pulsation, there's no cardiac output. And then we started to pace. And once we have effectively captured, we have halved the ventricular rate to 150, and you can see nice pulse oximeter wave here as the ventricle started to eject by halving the ventricular rate. So this was actually the life-saving option in this case, and it gave us time to proceed with amiodarone safely because we were no more in an emergent circulatory collapse situation. And I think we proceeded with the pacing for several hours until the focus has slowed on amiodarone. And this was how we saved this child without going on ECMO. And to do this, we need a transesophageal pacemaker, which is a dedicated pacemaker with 10 millisecond pulse duration. You cannot do it with a normal external pacemaker because those pacemakers have maximum of 1.5 or 2 milliseconds pulse duration, and they are not able to capture the atrium. So you need a dedicated esophageal pacemaker to do so. So the further course was that we achieved control of tachycardia by amiodarone within 24 hours. We could discontinue the esophageal pacing, LV function normalized, no MI within 72 hours. And our conclusion, and we continued for some time with amiodarone, and then I think switched the child to Satal, if I am correct. But we had no recurrence of the tachycardia anymore. So the conclusion is sometimes faster may be better, despite that it sounds strange. But in this case, by increasing the atrial rate by pacing, we actually achieved control of rate control of tachycardia. So now we may discuss the case or have questions.
So it's interesting. Did you after how long this child was under amiodarone, or have you been following him after that? And how long was the follow-up?
Yeah, we had the child, I think 1 year on amiodarone till reaching 1 year of age. There was no recurrence of tachycardia on serial holters, and the dose of amiodarone was gradually decreasing just by increasing, just with the course of increasing patient's weight. And then we discontinued and we had no recurrence. And I think this is conform with the data on focal atrial tachycardia in neonatal and infant age, that around 70% disappear spontaneously.
Good. So I think the tracings were clear enough. I don't know if is there anyone wanting any questions. You can write them on the chat. Otherwise, I think we can move forward for the next case, and maybe we can come back to any question if there's some on the chat.
Okay.
Thank you, Jan. Nice case.
Yeah, thanks. I think there is some lessons learned that I didn't project before. So, of course, SVTs may be sometimes very nasty in small kids, and everybody knows of cases with difficult to manage SVTs. And what you have to do really well is to do a differential diagnosis so that you know what you are treating. And primary pharmacologic approach may not work in circulatory collapse because the drug is not effectively transferred to the coronary and cardiac muscle. And initial rate control, as in this case, might be life-saving. So the next case is tachycardia and heart failure in a 4-year-old girl who presented with wide QRS complex tachycardia. There was repeated interruption by isolated sinus beats. And this is how the tachycardia looked like. So we have a wide QRS complex tachycardia with superior axis and right band branch block morphology. The heart rate is quite fast, it's around 270 per minute. And of course, the first question is the diagnosis, but as the child first was transferred to a local hospital, this is what they have tried to stop the tachycardia. The child is very unstable hemodynamically. They have tried verapamil, esmolol, propafenone, and they showed no effect. And then they thought of ECMO, and in the meantime, they have discussed with us the transfer. So the first question is, what kind of rhythm is it? Is it supraventricular tachycardia, ventricular tachycardia, no specific type, ventricular tachycardia from the left posterior fascicle, or ventricular tachycardia from the right ventricular outflow tract? We can stop the webinar. The people are educated, Ninke. Everybody knows almost everybody knows the right diagnosis. Yes, yes. According to the morphology, it's the ventricular tachycardia from left posterior fascicle, a quite common tachycardia, not really common, but if such children have ventricular tachycardia, is relatively frequently this type of tachycardia. The diagnosis is made from the morphology of the QRS complexes. Of course, if you would be 100%, we would have to give adenosine, see whether there is VA dissociation after adenosine. And this was actually done, but we don't have the ECGs from the local hospital. So at the time the child arrived, we had the diagnosis of the left ventricular posterior fascicular tachycardia. So I try to close this and to move again. Okay. Now we have learned how to proceed. So this was the echocardiogram at the time of arrival. And you can see poorly moving left ventricle during tachycardia, moderate mitral regurg. So the situation was not really stable. And as I told you, they were considering ECMO. But finally, we have started with amiodarone. And poll question. Okay, so now I gave the answer. So anyway, start voting. What is the therapeutic suggestion now? Because people may have other opinions. We have started with amiodarone. The reason why we didn't go, the reason to use adenosine would be a diagnostic one, and that has been done actually in the local hospital. So otherwise adenosine would not stop the tachycardia on the long term. cardioversion in the situation where we have the interruption of tachycardia by spontaneous sinus beats, again, would probably not be helpful because the tachycardia would initiate. ECMO was prepared and was thought about, but we didn't need it finally. And we were able to stop or to decrease the tachycardia rate with amiodarone effectively. And this is how the tachycardia looked like after amiodarone. So you can see some irregularity in the tachycardia. We have slowed it to 200 to 40 BPM and further down. So at the time we made the next therapeutic step, the tachycardia was running around 150 beats per minute. So the child was stable at that time hemodynamically. Now this is the schematic representation of left posterior fascicular VT, and the reentrant circuit is formed by the so-called P1 fiber, where is a delay in the conduction through the P1 fiber. Then it goes through the left posterior fascicle back towards his bundle and out of the P1 fiber again. And this is this kind of the reentrant circuit. And the P1 fiber may connect with the left posterior fascicle at various portions of the fascicle, either distally or in the mid portion or even proximally. And the ablation strategy is mainly directed towards ablating the insertion of the P1 into the left posterior fascicle. And this is the also the location where there is earliest ventricular activation mostly. So we proceeded with ablation. The child was, I think, 15 kilograms. So it was a small child for VT ablation, but we thought it's probably the only option on the long term to manage the tachycardia without having the need for long-term amiodarone. And when we would continue with amio, we would likely suppress the tachycardia, but then it would be quite difficult just to stop and wait for weeks and don't know where tachycardia will reinitiate again, with the risk again to get into heart failure. So this was the ENSIDE map, ENSIDE 3D map of the approach, and you can see the reconstruction here on the left side with AP view. This is tricuspid annulus, this is right atrium, inferior superior vena cava, aorta. We used a retrograde aortic approach. We put the catheter into the left ventricle, and we mapped distally the site of the earliest ventricular activation. This is mapped by the color map here with white to red coloring of the earliest activated area, and we were lucky to achieve here with just 2 ablations complete elimination of tachycardia. And we used an irrigated catheter because at this spot with a non-irrigated catheter there was no energy delivery because of quick rise of temperature at the catheter tip, because the catheter tip has not been cooled by enough blood there. So this is the signal at the successful site. You can see a local ventricular potential preceding the QRS complex, and this is again the schematic representation. We did ablate at this portion of the circuit, and this is the ECG afterwards, which shows sinus rhythm, and we had no reappearance or recurrence of the tachycardia since that. So we were lucky to manage this case with amiodarone and ablation. So I think we may, I don't know if I have a conclusion. No, I don't have any conclusion here. Okay, so we may again discuss it.
Good, thanks, Jana. Is there anyone? Okay, there is the chat. Some questions here. Thank you. Can you show the ECG, please, again? I think that this is a very nice case, and always ventricular tachycardias for us are less common. So we are more kind of restricted in terms of medication, and it's always, we want to see aberrancy everywhere rather than ventricular tachycardia. But I think it's a very nice explanation. I just wanted to ask you, Jan, in those patients, probably not in this one, which has a very focal tachycardia, very specific tachycardia, but in those patients having different types of ventricular tachycardias, like anterior, left anterior, left posterior, then you have a whole bunch of a Purkinje system, which is ugly itself. Do you consider genetic test in those patients in order to see if there is a channelopathy around? Probably not for this one that you just cured with ablation, but for those that, even though we perform an ablation, then we have another fascicular tachycardia, and then we have another, and it's kind of a very recidivant treatment. Do you consider them?
Yeah, if the tachycardia will not fit 100% into a specific picture, like left ventricular posterior or RVOT, idiopathic tachycardias, and if we would have some suspicion that there is more than just idiopathic ventricular tachycardia, we would go for genetic testing. In this case, I think we didn't have the suspicion because we have nice monomorphic VT with a clear morphology. And but you are right that if the diagnosis is not clear, we do genetic testing. No. Yeah.
Okay. So I think it was really clear, this case, and maybe we can, it's 20-2, so maybe we can move forward to the next case. So you can present for us.
Okay, so Teresa will take over for the last case. Yes. And
I'll try to be quick with 5 minutes, but I would like to present the case of a 80-year-old girl who was presenting with palpitations at our clinic, and she was feeling these palpitations for a few days already. We were asking the parents prior to admission if they noticed anything unusual, and they said that she was otherwise a healthy child, no complaints whatsoever. Just a few months ago, they noticed that she was a little bit more tired, sleepy, and she wasn't as active as she used to be. So at the beginning, we knew that she's in a higher heart rate. So we did an ECG, and this was her initial ECG, where you can see that it's a narrow complex tachycardia, supraventricular, and you can see the P waves here in 1, 2, 3 AVF positive. And it's a little bit more difficult to see P waves in the precordial leads, but the tachycardia was having extremely variable cycle length, which was changing within a minute to minute. So in the next minute, it looked like this. So the heart rate before was around 230, and then it was around 110. And now you can see again clearly the P waves here, but also the P waves in the precordial leads, especially in the right precordial leads. It's extremely negative, so it doesn't look like sinus, and it looks like it goes from the right to the left side, plus it goes from anterior to the posterior part of the body, of the heart. So we concluded it's a diagnosis of focal atrial tachycardia. As in every patient, we always perform echocardiography, and this showed severely decreased function of the left ventricle with ejection fraction biplane. It was around 20%, and you can see severe mitral and also tricuspid regurg. It was there. We concluded that this was the result of high heart rate for a longer time, and so it was like tachycardia induced cardiomyopathy in this kid, and we started a treatment as we used to in these kids. So we started the digoxin and ivabradine immediately after the admission, And this treatment showed up to be successful because within a few hours, the kid was in sinus rhythm. And here you can see the change in the morphology of the P wave, especially in the right precordial leads. It's not negative anymore. It's clearly positive. It looks like sinus. The kid was doing well. The heart function, the left ventricular function was improving. So we decided to let her go home on this combination of digoxin and ivabradine on the 4th day of hospitalization. But she came back. She came back 6 days after the initial presentation, and she appeared at our hospital because her parents found her on her bed in the morning, unconscious, gasping. They started lay cardiopulmonary resuscitation, called an ambulance. There was a ventricular fibrillation, which was shocked and burst into the sinus. So she arrived to us in sinus rhythm, but she had recurrent episodes of this polymorphic ventricular tachycardia that resembles torsades a lot, but was a little bit specific that it was always triggered by this ventricular complexes with quite long coupling interval, which was around 400 to 600 milliseconds. So we were asking ourselves, why could this be? There are some possible explanations. She was on a digoxin ivabradine, so maybe could it be high levels of digoxin in her blood? We tested the digoxin level and it was 1.4 micrograms per liter, which is higher than we're used to, but it's not really a toxic level of digoxin. The potassium was also on the low normal range. It was 3.5. And we also were not sure whether there is not some underlying other condition, especially atypical CPVT. So because there was a lot of recurrent torsades, and she crashed again during the day at our hospital, and she was sedated, intubated. So we decided to start with beta blockers and flecainide. Unfortunately, this didn't lead to suppression of the ventricular activity on the ECG, and you can see that it was very often the ventricular complexes that were not monomorphic. Plus, during the sinus rhythm, there was marked prolongation of the QTC interval in this kid. So we decided to stop flecainide, and she was only on beta blockers. The atrial activity arose again with stopping the ivabradine, so we started it again. But during this whole period, she was having this torsades or ventricular polymorphic ventricular tachycardia. And at the end, we decided to supplement potassium. Since then, we didn't see any ventricular tachycardia, but still we decided to provide her with dual chamber ICD with higher dose of beta blockers. She was prone to bradycardia, so we paced her at the pace 80 beats per minute. And she was discharged home in a good general condition. She didn't have any arrhythmia, and she was only on beta blockers, oral nadolol, and supplementation of potassium and magnesium. Further, she was followed up, and she has experienced this recurrent episodes of palpitations, which was consistent with focal atrial tachycardia, and she didn't tolerate it well. So 2 months after the discharge, we decided to perform EP and ablation. Professor performed it, and there was a focus found on the anterolateral part of the tricuspid annulus, and after ablating this spot, she was free of focal arrhythmia, and up until now she's doing well. In the ICD memory, there was no ventricular arrhythmia, no shock, no therapy, and so now we're still asking what was the initial diagnosis, why everything happened. We performed, of course, genetic testing. The NGS panel was negative with 200 and more genes. No likely pathogenic or pathogenic variant was found, not even VUS. The whole genome sequencing was also inconclusive, and we're trying to explain these polymorphic ventricular tachycardia episodes. Could it be tachycardia-induced cardiomyopathy, different myocardium that was prone to other insults like higher digoxin level or lower potassium, or all of them together? So we don't know. If you have any other suggestions, we would like to hear them.
Now, Georgia, the case is yours. We need some advice.
Yes, it's very nice. Did you get? Yeah, it looks like you would love to see a KCNJ2 mutation, right?
Or we were looking for these typical CPVT genes like tridin,
yeah,
THRL, calmodulin 1, 2, 3. Everything was negative.
Yeah, I know, but it looks like the way, I mean, the fact of the potassium levels.
Yeah, exactly, like long QT type 2, but the torsades are not typical for long QT syndrome with this long coupling interval. Plus, with the focal atrial arrhythmia, we were really suspicious about the CPVT.
Yeah, and you don't have nothing in ryanodine, right?
No, ryanodine was completely free of any mutation, not even BOS, nothing.
Yeah, we just had a couple of, I think I pulled this case in the panel for discussion. It's a case of ryanodine mutation, pathogenic ryanodine mutation in patients that they are presenting as atrial arrhythmias rather than ventricular arrhythmias, but the mother died of sudden death at 27. Okay, so there is some ventricular effect. But these two kids are having so many atrial arrhythmias that atrial fibrillation, atrial ectopy, atrial tachycardias, polytopic atrial tachycardias. So, there is a part of cardiomyopathy, you know, this kind of ugly ventricles, and that you don't know if it's the tachycardia or it's the cause or the consequences. I mean, exactly the same questions you are pulling. So, yeah, it looks like there is one ECG. Can you just move backwards, please?
This one?
Yeah, this one you don't have to. You really.
Two morphologies.
Yes.
Yeah, it's a different morphology. We were just talking about it. Whether sometimes we can see it in couplets. That's the second QRS complex. It's a little bit different. I was asking whether it could be due to the short RR interval.
Coupling. Yeah. And do you have a previous one, like a 12-lead ECG normal?
Sinus. I don't
know.
In sinus. But it was completely normal. So, oh, well, it's here. Yeah, we just have it here.
Well, I mean, the QT interval, it's quite. But in V3, you see this type of kind of longish end, which does not make. This is not a clear normal QT, and probably you have something related to this repolarization, which is not normal at all. And clear enough that then when you have a QRS on the T wave, you start doing couplets and maybe you start doing this torsade. So it really looks like the situation you would see in a repolarization abnormality.
Yeah.
So
that's what we thought. That's why we did the NGS panel for all of the long QT genes.
Yeah.
And, but this ECG is also in a phase when she was in a left ventricular dysfunction, dilated left heart and everything. So.
And you don't have now a present.
We do have it, but I don't have it in this presentation. But it's completely normal. There was no prolongation afterwards at all. It didn't.
Okay. Yeah. And when it tachycardies and bradycardies, you don't see any abnormality.
No.
Okay. Not really. But I didn't know whether Teresa mentioned it, but we had quite huge QT prolongation after flecainide. Which was.
That's why it was stopped.
Strange. That's why we really stopped it, because it was not helpful in suppressing the TDPs and it caused QT prolongation. So So we had at least drug-induced QT prolongation.
Okay, which looks like more rather than instead of long QT3 that you would see a shortening with K9. It's more kind of a potassium-related thing. But then you have all these kind of very rare genes related to more CPVTs, which does not really match with the Torsat, but this kind of mixed phenotypes in patients that sometimes they are really a nightmare, and of course you don't know. I mean, at the end you need to just cover yourself with the beta blockade, which will give you a little bit more of homogeneity, and of course make sure that potassium levels are good enough. When you see so much of a normality on the potassium, when you have many problems with the potassium, normally this looks like Andersen-Tawil type thing. And they don't have any facial feature, right?
No. And
nothing, not in the fingers, nothing.
It was normal. There was no mutation.
Okay. Yeah. So I probably we will have a genetic answer in the near future. Meanwhile, I will cover the child with nadolol and beta blockades, and see. Can you control now with the atrial tachycardia with this combination?
She doesn't have any. After the ablation, there was no recurrence of the atrial tachycardia. She's in sinus. No ventricular, no atrial ectopy.
Anyway, but you will keep nadolol, right?
Exactly.
Yes.
She's on higher dose of nadolol. It's around 2.5 milligrams per kilo, plus the supplementation of magnesium and potassium.
Yeah.
Okay, fine. And we are checking her when she was in some when she had infection or something like that. We also checked the blood test and everything. So we increased the potassium, but she's staying on beta blockers and this.
I have another question. When you were doing the atrial map, did you have problems in trying to pace the atrium? Let's say, were there any areas of low voltage in the atrium somewhere?
I don't think we have mapped the whole atrium.
Okay.
But as far as I know, we did not have any problems with capturing the atrium, and the atrial lead from the ICD is also functioning well. So at least in this way, we have not seen any fibrotic areas.
And family, nothing at all, right? Family has nothing.
No, we checked them cardiologically, both parents, all of the sisters and brothers. They're a big family, and everyone is okay. Normal hearts, normal rhythm.
Okay, very interesting.
And actually, if you see the origin of the tachycardia, it's like a peritricuspid focal tachycardia, which the focuses are sometimes found at that locations. So it's probably not a diffuse myocardial disease of the atrium.
And there is no epstenoid form at all.
Anatomy of the tricuspid valve.
Okay, no, how you call that? Eustachian valve.
I'm not sure.
Okay.
I can check this echo, but I don't think so.
No, at least not huge.
No.
Yeah. No. Okay. Yeah, very nice. Wow. Very nice. I will go through patients and see all these rare atrial tachycardias that sometimes we are more than sure there is something underneath that, not just the focus. But if we can control the tachycardia, at least we have no cardiomyopathy related to that. So I think you did a great job that, and congratulations. And I think in a while we will have some genetic condition underneath that.
Yeah, we hope so.
Yeah. Anyway, so it's just 2 minutes left, and I think we should finish this webinar. Thank you so much for this to share these nice cases. And I think that Nienke has an announcement, nice announcement for the next webinar.
Yes, the next webinar will be at the 22nd of February. It's the last Wednesday of February. And then we have the congenital heart disease thematic area talking. And of course, you can subscribe to this webinar again. So thanks a lot, everyone. We're a little late, but it was very nice, and I don't think it's really a problem. We didn't lose a lot of participants. So have a nice day, and thanks a lot.
Yeah, thanks as well. Goodbye.
Bye.
Goodbye.
Bye.
Bye.